First of all, I would like to thank you all for giving us the opportunity to put the ECHO label on this program that's already been running and very established. My name is Jackie. I'm a member of the ECHO team. I'll start us off with a few announcements and introductions, but real briefly, for those of you who are not familiar with ECHO, it began at the University of New Mexico about 18 years ago, pretty much as a way of empowering primary care physicians with the knowledge to be able to treat hepatitis C patients, since they were struggling with long wait times and long travel times to see specialists at the University of New Mexico. So again, we're delighted that you're allowing ECHO to be part of your work. So when we're doing the ECHO model, we'll start each session with just some brief announcements and introductions. And that's very similar. It'll be followed with a lecture and case presentation, similar to what's been happening so far. During the lecture, as always, please feel free to put your questions into the chat. After the session, you will receive a survey link to provide feedback on the session. So we want to ensure that any feedback that you have, we can use that to continue to make this as an effective use of your time as possible. We also, I believe, are giving CME credits for this, so it's very important that the evaluations are submitted for that purpose. So moving on to our brief introductions, I would ask if you would please put your name and email address into the chat function for our record keeping purposes, and again, for giving credit for those who are able to attend. Please stay muted unless you're speaking, but you can also use the chat for communicating, whichever works best for you. We certainly encourage the use of webcams, but we do realize that it's 10 o'clock at night for some people. So if a camera is not possible, that's fine as well. We are recording these sessions, as I mentioned, for educational and quality improvement purposes. And in the spirit of ECHO's model of all teach, all learn, we're on a first name basis during the session. So today we have a lecture and case from Dr. Agha, and I'm going to turn things over to Dr. Farouk. He is one of our facilitators for today, and I'll let him introduce our hub team, and then we can go ahead and get started.
Thank you, Jackie. I personally feel that we should just jump in right now. I think everybody knows everybody. So over to you, Irfan.
Thank you very much. I'm going to share my screen and get on with it. All right. So as this is a CME talk, I want to declare I have no relevant conflict of interest for this talk. So what we're going to do is we're going to talk about Mpgn today. And the first thing that I want to say, and I can't reiterate it more, is that Mpgn is not a diagnosis. It's a pathologic lesion. It's a diagnosis of state, but not a diagnosis of disease per se. And so when we talk about this, we have to understand that all it is going to tell us is the morphologic endpoint of a process of chronic injury response and remodeling in the kidney. And so when we see this diagnosis, we then have to ask the question, what is causing the Mpgn lesion? And unfortunately, like an onion, when we answer that question, we have to then answer the question, what is causing the cause of the Mpgn? And it is at that level that we are able to adjudicate therapy appropriately. And even then, it's a little murky, as I shall allude to in a bit. So whenever there is injury by way of a proliferative glomerulonephritis, there are several fates that can happen. It can resolve. So we see this in children all the time. You develop a proliferative glomerulonephritis post-infection. And once the infection goes away, the Mpgn resolves. And if you biopsy that patient 5 years hence, the kidney would be completely normal. Sometimes the infection can be very significant. It may be crescentic. But once it heals, it can resolve and all will be well. But if there's a pattern where there's persistent injury, and especially if there's some permissive underlying complement defect mediated conditions then what you will see is this grumbling process. And what you then start seeing is the stigmata of injury, stigmata of repair, and some stigmata of resolution. And that appears as an Mpgn lesion. So let's take a look at this cartoon. This is the normal glomerular barrier. You've got the endothelial cells, you've got the glomerular basement membrane, and you've got the podocytes on the other side. Now, let's assume that there is an antibody antigen mediated reaction. Let's suppose this person has got lupus or IgA nephropathy or something or the other. And so the antigen antibody complex is going to fix complement, and this antibody antigen complex as well as the complement proteins are going to start depositing on the endothelial as well as the mesangial surfaces. And once they attach to those cell surfaces, they're going to cause damage to those cell surfaces. And so eventually what you're going to see is direct damage because of the complement mediated actions. You can see this terminal complement pore being drilled into the endothelium, and then anaphylotoxins will recruit an inflammation. So you start seeing the process as Dr. Latif is going to explain to you as it would appear in the microscope. So you will have what is known as endocapillary hypercellularity. So I want to be very careful that this is the preferred term, because when we used to say endocapillary proliferation, that's how all of us have learned to refer to these lesions, proliferative lesions. There's actually nothing proliferating here. It's not like the endothelial cells are dividing. What's actually happening is that inflammatory cells, monocyte macrophage system, as well as the polymorphonuclear system, is actually being recruited here. And it is these cells, along with inflammation and swelling of the endothelium, that cause loss of the capillary space. So what you see is these angry looking glomeruli with a lot of cells where there should not be cells, and loss of capillary lumina, not just because there's cells there, but because the endothelia are swollen. And by using different stains, you can actually look at the cytoplasm and see how swollen it is in different cuts of pathology slides. And then what is now happening is that the basement membrane so what's happening is that the basement membrane is getting damaged, and eventually what happens is that the old basement membrane is sitting here. You got a whole layer of debris. These are the deposits actually, and they, depending on what flavor of Mpgn you're looking at, are either complement protein products, or they are antibodies as well as complement proteins. And in certain circumstances, you also see fibrillary deposits in there. So new and basement membrane starts coming up, and you then start developing the appearance of what we call tram tracking, or doubling of the duplication of the basement membrane, because now what's happening is you've got this old basement membrane, you've got this new basement membrane, and you've got all this junk in the middle. So that is essentially the hallmark of the Mpgn lesion. You've got inflammatory cells, you've got endocapillary hypercellularity, and you've got stigmata of damage and repair to the glomerular basement membrane barrier. And when you see this, you see a chronic and sometimes active process which is causing progressive loss of renal function. So this does not happen over days, this happens over weeks and months. So when you look at this kidney under the microscope, this is what you see. And I'm going to turn over to Dr. Latif here, who is going to walk us through the pathology, and I'll try to work with the mouse. So Shanila, if I'm at the wrong place, direct me to the right target.
Thank you so much, Irfan bhai. So yeah, this is a classic picture of Mpgn, which we see on H&E stains. The most striking is the lobular accentuation of these capillary loops. Each lobule, you can see lots of cells, lots of nuclei right there. It's definitely, if you count each lobules, is more than 10 cells or 15 cells, but normally you should not see more than 3 or 4 mesangial cells. So these are all monocytes, neutrophils, that's closing the capillary lumina. So when the capillary loops are closed, that's why you don't see much red blood cells. There are few red blood cells I still can see in these open capillary loops. So that's why this is called Mpgn, because the increased cellularity, lobular accentuation, and collapsed capillary loops. That's a classic HNE. And this is a silver stain. The black staining is the basement membranes. Usually you see duplication of the basement membranes on silver stain. There is some in this picture, but it's very lightly stained. That's why it's not very prominent. But if you go to next slide, yeah, that's a very classic one. On your 1 o'clock location, oh, actually, yeah, let's go, yeah, either one of them. Yeah, this is a good one too. You can see that the pink is the deposit and the black is the basement membrane. So you still can see the old basement membrane and then the new basement membrane underneath the deposits. So on silver stain, we call it tram track appearance for Mpgn. That's a term we use pathologically because it's a duplication of the basement membrane, as Irfan Bhai said. The healing process is the new basement membrane and the old basement membrane is the ones that's injured. Next one. Yeah, this is another silver stain, and this one, yeah, right there, exactly the two basement membranes, and there's some deposits in between them right there. I believe this was a dense deposit disease. That's why the deposits are smaller, elongated like a sausage shape, but not much endocapillary proliferation here. There is some, but not much, and the capillary loops are still open. This is, yeah, so this is a IgG, Irfan Bhai, right?
That's right, yes.
It's IgG. You can see the linear staining right there, but there is some granularity to this staining also along the capillary loops. They are also in the mesangium, yeah, right there. So the deposits are basically everywhere along the capillary loops and in the mesangium for IgG. And this is the C3, almost similar pattern. So it simply means it's immune complex mediated Mpgn and positive for C3 and IgG. So yeah, so this is a classic EM picture for Mpgn. The red arrows are pointing the electron dense deposits right there. And the white,
would you like to orientate everybody what the capillary space is, where the urinary space is, and where the mesangium is? I always have trouble on EMs to kind of orientate where I am.
Okay, yes, sure. So the white arrows, if you see, yeah, right there, pointing towards the capillary loops. So these are the capillary loops. The cells which are outside are the podocytes, or you can say epimembranous deposits should be there. And the capillary lumina is the one that's, right there is the lumen. And anything which you see the deposits on this side will be subendothelial deposits. And that big nucleus you are seeing attached, yeah, right there is kind of an endothelial nucleus right there. So all the deposits I'm seeing here is subendothelial right there, exactly. These are subendothelial deposits and then the mesangial deposits. So like on your 4 o'clock position, Irfan Bhai, go towards the red arrow right there. See, these are huge mesangial deposits right there, or you can say paramesangial deposits. So these are, the color of these deposits are immune complex mediated. The reason I'm trying to emphasize on the color, because we will discuss further the dense deposit disease, the color of those deposits should be dark, very dark black. As you see some of these dark dots here, that should be the color of dense deposits. But these are immune complex mediated deposits. That's why they are more close. The color is more close towards the regular basement membranes. Yeah, right. This one on your right hand side, you see the duplication of the basement membrane. So the deposits are the white arrows in the middle, right there. These are the deposits, and the basement membrane towards the capillary. Yes, this is the new basement membrane, and then the basement membrane above the deposits is the old basement membrane. The old one is damaged, but on EM you don't see those holes, but it's functionally damaged basically. It won't function normally. And this picture is classic for dense deposit disease. So these are very dark color, and as you can see, more close to the intensity of the color looks like red blood cell. There is a red blood cell in the middle of the right. This is a red blood cell. So if you compare with the red blood cell, the color of these deposits are very dark, and they are along the basement membranes. So like it's on top of the basement membranes. These are like sausage shaped, dark, dense deposits. So this is dense deposit disease, which also a type of Mpgn, I guess. Now it's C3, it's in the umbrella of C3 glomerulopathies, but we also call it Mpgn type 2. Okay, so this picture is very nice because it tells you where to start. So once you see the Mpgn pattern or double contour of the basement membranes, you look at your IF. IF is positive, then you know it's some sort of immune complex mediated disease. Then you go further and see if the deposits are subendothelial or subepithelial, or the location depends on the further classification. Then if IF is negative, completely negative, then you think about chronic TMA, or if it's in transplant patient, you think about transplant glomerulopathy. We will further discuss the IF positive membranoproliferative pattern. So right now, I mean, there are so many diseases in the differential. I don't want to. Okay, so this is endocapillary hypercellularity. That's another feature of Mpgn. Then you look at what type of IF are positive. If it's IgA nephropathy, you should have IgA deposits. If it's full house, you think about SLE like lupus. If it's IgG and C3, then you have to see EM if they are organized deposits or not organized deposits. So organized deposits are all cryo, and non-organized are infectious processes. There are a few other differential in organized, immunotectoid, and there's one more, I forgot about it, but that's fine. Then when you have a monoclonal deposits, you have to think about if it's some sort of patient has some multiple myeloma or lymphoma or other monoclonal diseases. And then the C3 dominant. C3 dominant is the one that's only give you C3 staining most of the time, very bright on IF. And then we further do EM and divide it into two subcategories. One is dense deposit disease, and the other one is C3 glomerulonephritis. Basically on EM, the location of the deposits tells you if it's C3 glomerulonephritis, in which you have deposits everywhere. But in dense deposit disease, the deposits are only along the basement membranes and some in the mesenteric. So
Thank you,
having
Sheena.
said, okay.
All right, thank you very much. So when people started looking at MPGN, they came up with some types of MPGN, and it was based solely on electron microscopy. So if the deposits were subendothelial, we would call it type 1. If the deposits were subendothelial and subepithelial, we would call it type 3. Whereas if they were intramembranous and they were dense inside in shape and morphology, like Shanila explained, then it would be called type 2 or dense deposit disease. But this did not tell us anything about how or what these deposits were doing and how the disease would actually behave. So based on immunofluorescence, some of that was changed, and now we tend to look at it more on a mechanistic or functional, from a mechanistic or functional viewpoint. So when you have MPGN as a diagnosis, this is the electron microscopy classification, type 1, type 2, and type 3. But we also look at the immunofluorescence now. And if the immunofluorescence is positive for IgG or IgM or IgA, along with C3, then we call it an antibody-driven process or immunoglobulin-driven MPGN. So it doesn't matter where the lesions are at that point. It just looks like it's an antibody-driven process. On the other hand, if the C3 is lighting up and the antibodies are not lighting up or not lighting up enough, so either the antibody stains are negative or the C3 staining is 2 levels brighter, and pathology people have criteria to define what the level of brightness is. If it's more than 2 levels brighter than the antibody, then it is dubbed as a C3 dominant stain, in which case, depending on, irrespective of where the lesions are, we call it C3 glomerulopathy. So if your immunofluorescence for antibodies is negative, C3 is positive, it goes into the C3 glomerulopathy umbrella. If the antibody is positive, C3 shall be positive with it, it goes into the antibody driven umbrella. And that helps us figure out the causes. So if your immunoglobulins are positive, the corollary is that your classical pathway is engaging, which could be with an infection. And in fact, a post-infectious GN is a rather troublesome animal to distinguish from some of these cases here. It could be an immune complex driven disease, which is commonly seen with connective tissue disorders, and somehow or the other we end up with this morphology more with Sjogren syndrome and things like that. Certain cancers, in fact, and this was one of the earlier things that was identified, the association of an MPGN pattern with lymphomas, etc., and then some other issues. In the immune complex, I neglected to say that along with connective tissue disorders, we also worry about infections. So hepatitis B, hepatitis C, etc., can drive an MPGN response as well, and those are classic immune complex driven responses. Now, if your immunoglobulin stains are negative on immunofluorescence, but your complement C3 is lighting up, that tells you that the alternate complement pathway is engaging. And then you have two, actually now people are putting one other disease in there, but for the sake of this conversation right now, you've got C3 glomerulonephritis and dense deposit disease, which are sort of overlapping, but functionally these are disorders of the alternate complement pathway regulation, which end up with inflammatory processes which light up with complement but don't light up for antibodies, and they behave, we thought, behaved differently. So we felt pretty smug 5 years ago at having achieved this, that we now have a functional handle on this disease. But like in all things in science and in medicine, this probably has been a short-lived spot of joy, because we are now seeing that things always are somewhere in the gray zone and are not black and white, and we'll talk about that a little bit. So this is a picture of somebody who has hepatitis C, and they've got hepatitis C associated cryoglobulinemia, which is driving an Mpgn response. That's a classic antigen antibody complex driven disease. So this is a PS stain, PS methanamine silver stain. So you're looking at the duplication of the basement membranes here, and in the middle you're seeing these some large deposits. These are cryos for you. On the right side, again, another case with cryoglobulin-mediated disease. So you can see what Dr. Latif was talking about, this kidney, that this glomerulus that looks like a brain, lobulated, furrowed. You see no capillary lumina here. There's nothing there. And the reason there's no capillary lumina are because the endothelial cells are very swollen and the capillaries are chock full of inflammatory cells. So that's your Mpgn lesion right there. It is lighting up for, in this particular example, IgG and the kappa, and you can see these large deposits on electron microscopy, which are pathognomonic of cryoglobulinemia, so of cryoglobulins. So this is a cryo-driven Mpgn, which is driven initially by hepatitis C virus infection. Now, these deposits, the antigen antibody deposits can be, the antibodies can be polyclonal, like they are with cryoglobulins or with lupus or with IgA, or they can be monoclonal. So this is an example of a proliferative glomerulonephritis with monoclonal immune deposits. Again, this is the same picture that I showed earlier, the kidney that looks like a brain, chock full of inflammatory cells, no capillary lumina. So this is what is known as endocapillary hypercellularity. And when you do immunofluorescence on this, the kappa lines up and the IgG3 lights up. Lambda is negative and other IgG isotypes are negative. So this is a monoclonal IgG kappa, which is driving the PGN-MID in this particular case, but the morphology looks like Mpgn. Now, sometimes we see these cases and we say, okay, this looks like an Mpgn, and we do stains and we say, okay, the immunoglobulins are not lighting up and C3 is lighting up. So this is probably C3GN. And just a word of caution that you can actually sometimes land into a little bit of a minefield because at times your immunofluorescence fails, and there's a technique called unmasking of deposits using pronase digestion on formalin fixed specimens. So when you put when you've got tissue which is in formalin or tissue which is in other preservation media, sometimes the sites on antibodies that bind with the immunofluorescent stains are masked. So when you pronase digest the sample on a formalin fixed tissue, you can unmask those sites, then you can stain them again. So in this particular case, the initial IgG was negative, but when we stained the same tissue with IgG after pronase digestion, it lit up. It was also lighting up with IgG kappa and C3. So if we had done this without pronase digestion, what we would have seen was an Mpgn pattern. We would have seen complement. We would not have seen these antibodies. But after pronase digestion, we were able to unmask these antibodies. So this was actually a case of PGN-MID, sorry about the typo here, which was being driven by an IgG kappa monoclonal antibody, just like the previous case. But in this particular case, we were not able to see this initially because the stain binding sites were masked, and we unmasked that with pronase digestion, and we were able to land on the right diagnosis. Otherwise, we would have gone down the C3GN rabbit hole. C3GN, on the other hand, on light looks like what we have talked about. So this is mesangial expansion and some mesangial proliferation. This is not as angry as the other cases that we have seen. So you can actually see quite a bit of capillary lumina. But when you go over here, you see that there is some mesangial and endocapillary hypercellularity. And when you stain them, when you do immunofluorescence, this glom is completely negative. This glom is completely negative. This glom is completely negative. So no IgG, no IgA, no IgM, but the C3 lights up like a Christmas tree. And so now you know that this is a C3 dominant process. So your diagnosis at this point will be this is C3 glomerulopathy. We don't know if this is dense deposit disease or C3GN because that will be adjudicated on electron microscopy. So how does this happen? There is a lot of interest on complement and complement mediated issues in Mpgn physiology and pathology. So just to orientate, this is the classical pathway, this is the lectin pathway, and this is the alternate pathway of complement activation. Complement is a series of about 30 proteins which are in the serum, and all they want to do is to kill bugs. That's why they're there. It's a defense mechanism. So the classic pathway is activated by antigen antibody complexes. You can see the C1 QRS complex. It's a classic ficillin. For the lectin pathway, the classic ficillin is mannose binding lectin, which actually identifies mannose residues, which are part of carbohydrates, on bacterial cell surfaces. So once these ficillins are activated, they work the same way. They're going to cleave factor 4 and factor 2 and develop C4b2b, which is the classic pathway C3 convertase. The idea is to break up C3 into C3a and C3b. So we'll leave the classic and lectin pathways here, but these little stop signs are fluid phase controllers because we don't want these processes to run amok. Otherwise, we'll have problems, and we do when some of these things fail. So this is C1 esterase inhibitor, which blocks the runaway activation of C1. And as you would recall, if you've got C1 esterase inhibitor deficiency, you're prone to bouts of angioedema. Similarly, complement factor I is a fluid phase protein that would block some of the progression of C4 and C2 towards C3 convertase formation. Now, the alternate pathway, oh, by the way, C1 esterase inhibitor also blocks this ficillin because it identifies the molecule structure. Now, on the alternate pathway, things are very, very different. Now, the alternate pathway is always in a state of readiness. It's like the Rangers. Some of them are always on the border. And so what's happening is in circulation, in fluid phase, what you see is some of the C3 hydrolyze into C3 with this water molecule on, which then in the presence of factor D breaks up factor B into a complex of complement factor B and C3, which acts as the alternate pathway C3 convertase. But the important thing is, as soon as it breaks up a little bit of C3, this C3b that is generated by breaking up of C3 is going to go back and potentiate this problem. So there's some spontaneous takeover, and then there's this amplifying loop that is going on at all times to accelerate or to keep some C3 always ready, on the lookout to latch onto a surface it doesn't like. Now, therefore, we need to control this, and there's several things that are available to us to control this runaway amplification loops of alternate pathway generation, and we'll look at those. But suffice it to say, when you have C3 convertases form, they break C3 into C3b. Now, this is a cardinal molecule in complement physiology. Two different types of C5 convertases form, which is the next choke point in complement physiology. So one of them is the classic and lectin pathway C5 convertase, which now would have C4b, C2b, and C3b. That's one type of C5 convertase. And the alternate pathway convertase, which will have C5b, complement factor B, so big B and little b, with 3B, 2 molecules of 3B attached on either side. That's the alternate pathway C5 convertase. They both do the same thing. They're going to break up C5 into C5A and C5B. C5A is a very potent anaphylotoxin which recruits inflammatory cells, where C5B then goes looking for C6, 7, and 8, and then C9, and forms what is known as membrane attack complex. Like the perforins from T cell, these membrane attack complexes jump onto, are actually formed on target membranes, and they actually blow holes in them, which leads to death of the target cell. Now, again, just as we had control mechanisms for the runaway activation of the C3 amplification loop, we have control mechanisms to attenuate runaway complement activation. So there's cell surface, which are known as surface phase control mechanisms, complement receptor 1, DAF, membrane core factor protein, which is CD46, DAF is CD55, decay acceleration factor, and then CD59. All of these are active on the, these three are active on the cell. This is active in fluid phase to block progression of complement activation. And then there's proteins called vitronectin or clusterin, which actually chelate some of the membrane attack complex, do not allow them to attach to the target membrane. So you can see the vitronectin and clusterin are attached to the complex here, and this complex, which is the membrane attack complex, along with vitronectin and clusterin tagged to it, is actually circulating. This is known as the soluble membrane attack complex because it's obviously not stuck to a membrane. But if the MAC is allowed to stick to a membrane, it'll kill that membrane. So that's your complement pathway, and all of this is involved in one form of MPGN or another. So if you've got an antigen antibody mediated process like lupus or Sjogren's syndrome or hepatitis B associated MPGN, hepatitis C associated MPGN, cryoglobulin associated MPGN, sometimes Mpgn, you are going to see the direct pathway, sometimes the lectin pathway. So IgA nephropathy doesn't toggle the direct pathway, the classical pathway, it toggles the lectin pathway. Similarly, membranous nephropathy, which is not a cause of MPGN, doesn't go with the classical pathway, it goes with the lectin pathway. But suffice it to say, depending on some diseases, one or two of these areas are going to be attacked by the antibodies, which would lead to C3 convertase from the classical pathway, which will then lead to the C5 convertase from the classical pathway, and potentiation of this destructive and inflammatory response. On the other hand, there's many different diseases, acquired as well as genetic, which affect predominantly the alternate pathway arm, which then leads to C3 glomerulopathy. So if you're toggling this, you're in the antibody-driven MPGN realm. If you're doing this, you're in the C3 glomerulopathy realm. So let's focus a little bit more on the alternate pathway and what happens by way of control. So we talked about how C3 needs to convert to C3b to start causing problem. In order for C3 to convert to C3b, you need this molecule called C3 convertase. You can get to this through various different areas, but one of the commonest, which is perpetual, is the takeover, the autohydrolysis of C3, which then in the formation of in the presence of complement factor B, as well as complement factor D, will generate the C3 convertase. Once the C3 convertase gets to work on C3, it will cause C3BB to form, and this then starts the amplification loop. So you get more and more of this, then you start generating your C5 convertase and you start generating your membrane attack complex. In order for the body to control this in the fluid phase, you have complement factor H and complement factor I that start working on some of these proteins to take them away from circulation so that you don't have too much C3b going down to form membrane attack complex. Obviously, if you have complement factor H deficiency, either through genetic deficiency or through an acquired antibody that is intercepting the action of complement factor H, then you will have runaway activation of the alternate complement pathway, and you'll have more membrane attack complex. You'll have more inflammation through C3a and C5a. So factor H deficiency, factor I deficiency are all associated with some forms of C3GN or atypical HUS, and depending on the abnormality, as we shall soon see, they can differ. Complement factor H related proteins are a very interesting set of proteins which actually regulate complement factor H and have pleomorphic effects on the complement pathway. I'm not going to go too much in detail, but in the next slide, we'll learn a little bit about the biology of this. And then there's autoantibodies called C3 nephritic factors, some monoclonal antibodies. So that's the MGRS associated C3GN, which can act as nephritic factors, and we'll talk about that by either blocking the regulatory proteins or activating this cascade. Similarly, on the cell surface, you have complement factor I, complement factor H, membrane cofactor protein, as well as CFHAR, other proteins like thrombomodulin, CR1, etc., all help in controlling the activation of complement proteins on the cell surface. So this is a little bit of a deeper dive in the biology of complement factor H and some related proteins called complement factor H related proteins. So complement factor H is the gene is present on chromosome 1, and there's a downstream of that gene. There's these 5 complement factor H related peptide genes, which are in a 3, 1, 4 to 5 orientation. And this is a highly, highly volatile part of the genome, and several problems happen. There can be duplications, there can be deletions, there can be fusions, and each time some of that happens, we know that it can lead to various different types of disease processes. So if there's a factor H CFHR1 fusion, so you got factor H here, if it fuses with CFHR1, you actually are fairly likely to develop HUS. Similarly, if you have a duplication in CFHR5, so this is CFHR5, if you have duplication in this gene, you get a fairly well-described phenotype of complement-mediated disease called Cfhr5 nephropathy. And what happens in this is, and this is very, very specific for patients of Cypriot, Greek Cypriot origin. There's a founder effect. That means some time ago there was one mutation in somebody which is now carrying through in that population, and it has a very well-defined course. About half of the people slowly progressive, about half the people above 50 develop end-stage kidney disease, and there's many different things in there as well. So when we look at these disorders now, we ask for complement genes, and as time is going by and we are getting more and more of this information, we are able to put 2 and 2 together. We are able to see, okay, which type of genetic problem is going to cause a problem. So CFHR3, CFHR1 deletion actually puts you at a much higher risk of developing anti-factor H antibody, and you get either HUS or C3 glomerulopathy based on that. And I'm very sorry, I forgot to put the reference for this paper, and I'll correct that. So these are C3 nephritic factors. We talked about them a little while ago. So C3b-BB is the alternate pathway C3 convertase, right? And the C3 nephritic factor here is going to attach to some neoepitopes here, and it would make this complex resistant to the action of factor H and factor I. So what factor H and factor I are trying to do is to break this up, But when you have a C3 nephritic factor here, it stabilizes this bond between C3b and BB, and then it will convert more C3 into C3a and C3bb, which would then amplify this loop and also go on and make the C5 convertase. Similarly, on the alternate pathway site, you have the C5 convertase, which is one molecule of BB flanked by two molecules of C3b, which is stabilized by properidin. And the C5 nephritic factor in the presence of properidin is going to stabilize this compound. It is going to make it resistant to the action of factor H, factor I, decay accelerating factor, membrane cofactor protein, and complement receptor 1. And so nothing is going to break this, and it is going to make more and more of membrane attack complex and anaphylatoxin, generate more inflammation, generate more disease. So that's how the C3 nephritic factors work, and they're all antibodies. Sometimes they can be polyclonal antibodies, sometimes they can be monoclonal antibodies. So this is one of those instances where you may have a monoclonal circulating protein in the blood, and when you do the biopsy and you look for monoclonal proteins, you won't find anything. And why is that happening? Because those antibodies are not leaving their fingerprint on the kidney biopsy. So this is one of those situations where there could be a secondary C3 GN driving the kidney insane, but there would be no monoclonal protein deposited in the kidney per se. The way that monoclonal protein is working is as a C3 nephritic factor agent, as a C5 nephritic factor, or as a nephritic factor for the classic pathway. And so along with thrombotic microangiopathy, C3GN in the presence of a monoclonal immunoglobulin is those two disorders where you do not need monoclonality demonstrated on kidney biopsy to ascertain an MGRS status. Now, the problem with these proteins, I'm sorry, I'm having a complete block, the nephritic factors, is that they're very, very hard to measure. So we have functional assays for them, and you can either look at them on various electrophoretic platforms, or you can use hemolysis assays. And hemolysis blood cells have been a particularly favorite carrier to look for these things because, you know, it's a very easy thing to measure. When the hemoglobin is released, the red cells die, you know that the complement thing did its job. But these are not very sensitive. None of these are very sensitive. Even the modern bead-based assays are not very sensitive. There are binding assays, usually on ELISA platforms and so on and so forth. These sometimes pick up stuff which is not functionally relevant. So although I have asked for nephritic factors several times, sometimes when I'm very sure that there's a nephritic factor there, I find nothing. Sometimes when I don't think that there's a nephritic factor there, I find something. So I think these things are still not ready for prime time. Although the first nephritic factor was described in 1969. So it's been 50 years, but we have still not gotten there. But I think there's a lot of smart people working on this in various labs, and hopefully we'll be able to get a more reliable nephritic factor assay. Now, another issue is this soluble MAC complex issue. So, when we started treating C3GN, initially it was like, oh, this is complement related issue. And so just like atypical HUS, if we give them Solaris, eculizumab, everything would be great. It turns out there's a very, very patchy response, and it's a much more complicated and nuanced disease because the disease may be active at different levels. Terminal MAC may not be causing the morbidity. The inflammatory part of it may be causing more problems. And so one way to look at it is to say, okay, let's measure terminal MAC. And if you've got a lot of soluble MAC in the blood, then that means that there is some activity which is being driven by the terminal complement pathway, and therefore those patients may actually do better with C5 blockade. Now, the problem with measuring soluble MAC in blood is that it is very, very fickle, very difficult to measure. In fact, it can form in vitro. So you draw the blood and soluble MAC will start forming inside the tube. So it kind of is all over the park. And again, we are hamstrung by our inability to get good assays for this disease process. And so you can actually stain it in the biopsies, and that's actually more reliable. So this is a biopsy. On the left side, you see a normal kidney, which is stained for soluble MAC, and you see there's some staining in the pole, but you see nothing in the glomerulus. And now this is a case where the patient's got atypical HUS, complement-driven HUS, and you see that it's really, really positive for SMAC. So you can surmise that this is a person who may actually benefit from complement blockade. So I was kind of talking about how we were very smug that we've got this all figured out. But the thing that has really surprised us is the difficulty in treating these patients. One would have thought that, it's a complement-mediated issue, complement blockade or appropriate immunosuppression should take care of this. But it is not so, and sometimes the responses are very surprising. So this is a very, very interesting paper, and this is I put this up so that we are all thinking about this. What they did was they looked at patients with Mpgn, be that immunoglobulin-driven Mpgn or C3-driven Mpgn, and performed an unsupervised hierarchical cluster analysis. Now, that level of sophistication in statistics is above my pay grade, but what they actually do in this is that they have various clinical laboratory pathology, biochemical features, and then they try to look at similarities. So each one of these lines is an individual patient, and then they try to pick up on similarity and try to bunch them in buckets. So somebody who is an immunoglobulin driven Mpgn may find themselves in this bucket along with somebody who was on pathology diagnosed as C3GN. And so they formed actually 4 different buckets, and then based on the performance of that, they made a 3-step algorithm to put them in these buckets. So these are pretty straightforward things, and when you look at them, you can try to start stratifying them. Now, this is not a randomized study, so I'm not suggesting you start doing this in clinic. This is just to help us understand the disease process a little bit better. And so cluster 1, for instance, had very high SMAC levels, low serum C3. On electron microscopy, there were mesangial deposits, there were some crescents, and the amount of mesangial deposits that you found in this cluster were much higher than other members. Cluster 2, on the other hand, had a high prevalence of likely pathologic variants of complement genes, just like cluster 1. They also had a very high SMAC level, but what differed in this cluster was that the glomerular staining was much stronger. In cluster 1, we had mesangial deposits. Here we had very strong glomerular presence of deposits. Cluster 3 had similar features, but their SMAC levels were low. And cluster 4 sounded like a SAD sclerotic variant, low variance, low presence of likely pathologic variants on genetic testing, low SMAC levels, no C3 nephritic factor, etc. And again, just to make a point, in cluster 1, there were 42 C3GN. So Dr. Latif had very confidently said, this is C3GN. 42 of them actually, based on their clinical, biochemical, and other features, found themselves together with immune complex Mpgns and dense deposit diseases. Similarly, in cluster 2, you had 2 C3GNs, but more immune complex Mpgns. Cluster 3 had more dense deposit disease. And cluster 4, which was the sad sclerotic type of deal, had a good sprinkling of both C3 and IC Mpgn. So see how we were thinking that we have got this sorted out, but based on these variables, it's still up in the air if we are classifying these patients correctly. And similarly, they looked at analysis of genetic mutations in the 4 clusters, and it turned out they had very different profiles, which then translates into biochemical behavior. And what they were able to see was cluster 4, the sad sclerotic variant, behaves very differently from the other clusters. They were all treated, obviously. This is a retrospective study, but if you're in cluster 4, you don't do well. And their algorithm cluster, the simplified way of doing it, actually performed reasonably well. Now, look what you find when you're doing this according to histologic group. You could have immune complex Mpgn, you could have C3GN, dense deposit disease. They look about the same. You can't tell squat here about what's going on. But by doing this, you might be able to tease out more. So, the question is math here, because this is essentially a mathematical algorithm, is math trumping histopathology? And that's a very, very interesting way to look at these disorders. So the reason I've spent some time on this is that as we go forward, we shouldn't remain frozen in time. Our understanding of these diseases and the tools that help us understand are increasing every day. So I'm going to quickly go over 2 cases. I'm not going to spend too much time on these, but these are meant just to help all of us appreciate these issues. So this is one of my cases, 40-year-old male of African descent, good health till about a month ago. He's actually a physician from Nigeria, but in the US, he is working as an IT consultant, so he changed jobs. He came in with edema and some hypertension, and his creatinine was elevated, and he had proteinuria. And this was a couple of years before he came to us. When he came to us, he had no known priors. He wasn't taking any medicines still. He had a creatinine of 1.4. His albumin was pretty low. His protein creatinine ratio was pretty high. He had proteinuria and hematuria. C3 was low. Connective tissue profile, infectious disease screens were negative. So clearly we are already looking at C4, which is not low. C3 is pretty low. So we're thinking, is there some C3 issue going on here? Pathology, Dr. Latif went over this very nicely. So all of us can now see a lobular kidney. You've got this hypercellularity. Many of the capillary loops are obliterated. So this was called Mpgn. He actually had a secondary focal sclerotic lesion here. So from our previous talks, you see the synecdoche and the sclerotic lesion. So this has probably been going on for some time. And he's got an adaptive Fsgs lesion. This is the PAS stain on that. You've got the trichrome, and you've got some fibrosis that is developing. And immunofluorescence negative for GAM and very, very strongly positive for C3. So you've got an antibody negative C3 positive phenotype, and on electron microscopy, I'm not going to spend a lot of time. Dr. Latif went over all of these. You got this capillary loop here, basement membrane. You've got these large deposits, and also a bunch of mesangial deposits. And look at these. There's a high power field, huge deposit, which is in an intramembranous location, but this is not consistent with dense deposit disease. Another view of the deposits. So we have a diagnosis of state. He's got Mpgn due to C3 glomerulonephritis. He does not have dense deposit disease. He has C3 glomerulonephritis, and we talked about 2 disorders in the C3 glomerulopathy umbrella, and we tease them out based on electron microscopy. And since we don't see dense deposit disease, we call him C3 glomerulonephritis. Is that enough? Is that enough to initiate therapy? No, it is not, because C3 glomerulonephritis can be driven by multiple things. So he's an adult. We screen for paraproteins. His kappa lambda ratio was a little high. He underwent a bone marrow. There was no clonality. And so this was rested. We didn't find any C3 nephritic factors, for whatever that's worth. What are the management options in this case? This is the initial study by the Lesion Group, which was published in KI, KI in 2015. And this is a retrospective review. Lesion Group, by the way, is the Spanish study of glomerular diseases group. which looks at what happened to these patients who were diagnosed with C3 glomerulopathy. And so this line here is patients who were treated with MMF and steroids, and the other two lines are for patients who got other immunosuppression, cyclophosphamide, rituximab, yada, yada, and no immunosuppressive therapy and just supportive therapy. And it looked like if you were on MMF and steroids, you did well. So there was a signal, and the signal was stronger if you had C3 nephritic factor detectable. So this is another study which the same group did, retrospective multicenter observational cohort, where they looked at people with C3GN and saw what they got. Corticosteroids plus MMF over a fairly long period of time, 120 months follow-up. And if you were on steroids and MMF in their hands, they did well. I don't find that great of a response with MMF and steroids, but in their hands, they found a very good response. And it was independent of pathogenic variants, so likely pathogenic variants in the genome complement analysis or nephritic factors or what have you. In this particular study, they found MMF and steroids performed better than other therapies or control. And this was actually also confirmed by the Columbia group. This was published in 2018. Jerry Appel, along with some Turkish colleagues. So this is a registry review of the Columbia registry as well as the Turkish registry, and they found pretty much the same thing. And they found that if you were on MMF and steroids, your response rates were higher than some of the other therapies. So it seems that there is a response, a signal for response. These are all observational studies. These are not randomized controlled trials, but there seems to be a signal for response for MMF. And what seems to be driving the responders versus non-responders is, I think, the duration of disease. If you let it sit for a long period of time, you're going to get into trouble. So if your proteinuria was low and your creatinine was preserved, you tended to do better. Eculizumab, I'm not going to go over all these. This is single patient data, but eculizumab is all over the place. Some people respond beautifully, some people don't. Our patient, we put him on MMF and steroids, no response. Then we put him on eculizumab, no response. About 2 years later, he was on dialysis, and he has been transplanted. He's about a year and a half out of transplant, I think, more or less, and he has not had a relapse, so he's lucky. So when you get proteinuria, hematuria, and you're trying to diagnose C3GN, you need to send out investigations, which in our hands in the US, we now send for complement studies in detail. If we find that there is a complement activation in C3GN, we treat according to disease activity. A lot of people, based on the Spanish data and Colombia data, try MMF. I have tried eculizumab based on SMAC staining, but that's spotty and difficult to get. But there are some labs that I'm able to send to who will do that. Mayo or Canada do it. If they've got proliferative lesions, again, highly proliferative lesions, those are the people who tend to respond to eculizumab. Most other people would put them on MMF and steroids. And it is important to rule out other problems. Mpgn is a particularly difficult diagnosis, especially when you're looking at the younger age groups and you're pretty close to the index infection. It can sometimes be a problem, but understand that what starts as an immunoglobulin-driven process may metamorphose into a complement-based product because just the infection, let's suppose somebody gets an osteo or infective endocarditis, that's a complement amplifying event. And if you've got an underlying complement activity problem, a complement regulation problem, you'll get into that trouble. So the second case, just to say that there could be other issues there as well. 56-year-old female, known fibrillary. She has been treated in the past. She actually did very well with that. Comes in with worsening proteinuria and deteriorating creatinine. We biopsied her again. You find the Mpgn pattern. You see that there's a tombstone of long-standing activity, again, a secondary Fsgs type lesion. We see some fibrosis developing in. an IgG and C3 driven process. So we know this is an immunoglobulin driven MPGN. We don't have the answer why, but the answer is there on electron microscopy, and you see these fibrils. And Dr. Latif will tell you that based on the size of these fibrils, you can actually make an assessment whether this is amyloid, or is it fibrillary, or is it an immunotactoid. So if your fibril size are 7-ish nanometers, then you're talking amyloid. If they're about 10 to 20, you're talking fibrillary. If they are more than 25, 30, you're talking immunotactoid. But what is not equivocal is the DNA JB9 stain. This is a recent development described for the first time about 3 years ago. And it's an immunoperoxidase-based platform on this picture. And this glomerulus is lighting very dark for DNA JB9, which is highly, highly specific for fibrillary. So we actually treated her with rituximab, she actually has stabilized. She's not going to get better. So victory in this is that her proteinuria has come down and her creatinine is still about 2.5 to 3 years after the event. And again, just as we saw in C3GN, if you've got low creatinine and a low amount of protein in the, a relatively low amount of protein in the blood, you're not going to progress and you're going to respond to treatment. But if you're tripping a creatinine of about 2 and you've got more than nephrotic range protein, you're probably going to have progressive disease with fibrillary. So we should try to catch people in this phase and then treat them like this patient was in 2014. She went back down to normal, was near remission rates for several years before she relapsed. And so in the paraprotein-based disease groups, fibrillary and immunotactoid, as well as cryoglobulins, will sometimes give you MPGN pictures. Light chain amyloid usually does not. That looks more fluffy and more like diabetes. So this is all I have for MPGN, and especially a little bit of a heavy dose on complement-based therapies. I will stop here and I will invite any questions. And I'm done in an hour, so I'm very proud of myself.
Okay, can I start with a question? This is Avas Sood.
Please.
Okay, so that case you presented, the first case, which has complement mediated injury.
Yes.
I think in those cases, it's not a good idea to start with eculizumab first rather than MMF.
Yeah, so that's, let me just go back to, you can still see my slides, right?
Yes, we can.
Because yeah, on one of the last talks, I was pontificating and I didn't have my slides up, so nobody would know what the hell I was talking about. So let me just go back to the complement picture to make that point. Avas, that was exactly my thinking 2 or 3 years ago. I'm like, in fact, more than that, the first time I saw C3 glomerulopathy really kick me was 2012. At that time, we knew very little about the disease. And I had this recur in a transplant. I don't know if Dr. Latif remembers that case. It was a young gentleman, a financial wizard from Florida who had sought us out in San Antonio to come meet with us for transplantation. We transplanted, and 6 months after his transplant, he developed nephrotic syndrome, and he had nephrotic range proteinuria. And so what happened in that particular guy was that he had a monoclonal protein. We treated it for a clone-based disorder. He went down like a rock, and in about 6-8 months, killed the kidney, went back on dialysis, and that was a terrible course. But your point is very, very valid, because you would think that this is a complement-based disorder. So if you block this here, you're not going to have problems, right? That's what you're thinking at this time. But the issue is that the complement disease pathways are very, very variable. So there are some complement diseases which are driven very heavily by this part of the complement cascade and not this part of the complement cascade. And that is why all this emphasis on measuring soluble MAC to see if this is dominant or not. Remember, I showed you the 4 clusters of C3GN or immune complex based MPGN and C3 based MPGN. there were two groups in there where the soluble MAC activity was very low. And so it was the C5a and C3a and some of these anaphylotoxins and inflammatory pathways which were driving that disease. It also depends on what your protection mechanisms are, what part of the fluid phase is activated, how much of the cell phase is activated. So, you know, it's a very curious thing. You have got issues with factor H. Some people present with atypical HUS. Some people present with C3GN. Some people have nothing. So what is the difference? So you actually can tease out the location of the abnormality on the gene. So let me just pull up the picture of factor H here. Factor H is a molecule with 20 CCPs, complementarity protein cassettes. And it depends, oh, where did that go? It depends on where the mutation is, which helps us identify what the pathology is going to be. Is it going to be something that would affect the cell surface mechanisms, or something that is going to affect the circulatory mechanisms? So this is factor H. This is the N terminal, this is the C terminal. These are the 20 CCPs of factor H. And if you're going to get abnormalities in this part, which anchors it into the cell surface, you're going to have cell surface problems. You're going to have HUS. On the other hand, this in the fluid phase, you're going to have fluid phase problems. So I jumped over this picture. This is a very, very complicated set of interdigitating bricks. And so the current thinking of us is that MMF and steroids seem to stabilize these disease processes, perhaps by non-specific anti-inflammatory activity, and perhaps they should become the backbone. And in selected patients, then you can add complement-based therapies. So in addition to eculizumab and revolutimab, the Ultimoris, the longer-acting eculizumab now, there are several other complement proteins that are in the pipeline, and they may be add-on therapies on top of MMF and steroids. But it seems to be more and more the first line of therapy for some of these disorders are MMF and steroids. The only time when I go for eculizumab first is when I see anger and a lot of inflammation and crescents in the glomerulus. And again, I've placed 2 or 3 people on eculizumab, and the results are all over the place. Like this gentleman that I presented the case of, he was on dialysis, started with 1.4, on dialysis 3 years. And he got eculizumab.
Dr. Aurangzeb, you're next, and I think there's a question in the chat as well, so which we can take afterwards.
All right. So how do you use C3 as a clinical marker, as a monitoring tool for treatment?
I don't. I mean, as a clinical marker, it's important to look for it, but I have seen people with rip-roaring C3GN and normal C3s as well. So it's not very sensitive. Unfortunately, we don't have any level 2 markers for any of these diseases. So C3 and C4 obviously are easy to do, and they're fairly reliable. I mean, you can track them. And so if it's coming up, that's good news. That means you're doing something, but sometimes you're actually blocking pathways lower than where the C3 is, right? So you may still have a low C3, but you may not be seeing stuff that's happening after C3. It's difficult. You know, if you see it, you say, well, the C3 is low, but it could be low because of many other issues. It's not very reliable. Factor H levels, factor I levels, these are not reliable also because the assays are not very good. So you have the clinical picture, which is level 1. Then you have the biopsy, but there's no level 2. And then you have the genotype, which is level 4. You're missing level 2 information. There's a lot of work which has been going on for almost 10 years now. Like I said, for these nephritic factors, the first one was described in 1969, and we still don't have reliable assays. So that is the Achilles of this science. We don't have good clinical information, so well, laboratory information. So we have to do the biopsy and then try to, it almost becomes like palpating the elephant. And you've looked at the cluster analysis that even when we are comfortable, oh, this looks like C3GN, it may not behave like it. It may behave as something else.
Yes, one more thing with it. Did you ever add MMF with eculizumab to begin with for an angry-looking C3 nephritis?
I have not done that, but that's not unreasonable to think. I've not done that. I think after the recent Spanish study, that's not unreasonable. I haven't done it though.
What about transplant? Let's suppose if the patient is having a C3 nephritis and for whatever reason, maybe C3 nephritic factor or whatever else. Now the patient is ESRD and he wants to get a transplant done in 2 months' time.
So there's a 50 to 60% relapse rate in kidney transplantation. I gave you my first patient from almost 10 years ago now. He had a nasty relapse and the kidney crashed and burned. I've transplanted 2 C3GNs in the past 2-3 years. One of them we presented. There's another patient that we transplanted about 6 months ago. The gentleman that I presented has not relapsed. The gentleman that we transplanted about a few months ago has had a very mild relapse, but he's chugging along on immunosuppression. So understand all of these patients are on steroids and MMF, so they're on good therapy. So as his kidney function has been very stable, proteinuria is under very good control. He's on immunosuppression and RAS blockade, and he's doing all right.
And from your previous answer, I would extrapolate that you don't monitor C3 post-transplant.
No. But a very low threshold to biopsy.
Thank you, sir.
So, Irfan, there was a question about the digestion thing you mentioned, the pronase digestion, right?
Yes.
So the question is that when do you do that? Is this something that's done routinely by pathology, or you have to specifically ask for it?
So it's not done routinely. Hang on, let me get to that slide so I can extrapolate on that, because we are not pathologists, so people may have a little bit of a difficulty in understanding the entire process. So I'll put the slide up. There we go. So essentially, just, think about it this way. You've got this patient who's got Mpgn. Forget about what's written here. You've got Mpgn, right? Now, when you think about Mpgn, you say, okay, it's either immunoglobulin driven or C3 driven, right? That's our paradigm. It's either this or that, one of the two. So what you do is you look at immunofluorescence. That's what we were saying. Oh, we are able to do a mechanistic classification of this based on immunofluorescence. Great. So you do immunofluorescence and all you find is C3. You don't find anything else. What would be your conclusion? Your conclusion would be this. You say this guy has got C3GN. He's got Mpgn. He's got nothing lighting up for immunoglobulins, and he's got C3, and he's got deposits to show for it, right? Because you look at those deposits, C3GN, you got to have deposits. You say, I've got the diagnosis made. Now, what you're looking at here is a false negative immunofluorescence for the antibodies. And the reason is those antibodies which are there, which are in the tissue, are not picking up the stain. So what they do is now they go back to the formalin block, they pick it up, put pronase in there. Pronase is an enzyme that digests some of these links, and that makes those links available for immunofluorescence. You then stain the pronase digested block with immunofluorescence agents, and now you've got IgG and kappa lighting up. So you would have called this this disease process C3GN based on the histopathologic criteria that we usually employ or deploy. But when you unmask these deposits, you'll get into this this issue. And this is not peculiar for this disease. There's many situations, especially when we are trying to adjudicate MGRS syndromes, where you have to use this technique to really make certain that your clonality is not a false positive or a false negative. There was a young female I diagnosed with membrane-like nephropathy with mass immune deposits. It's a very peculiar syndrome described in young females. It sounds like they've got some formatory of membranous, but when you actually do this, you find those monoclonal deposits, and you treat it appropriately. So this is actually being used in several laboratories now, but you need to know how to do this. And so technique and experience in this technique is important. So I know that Arcana does this. I know Mayo does this. So I don't know if Dr. Latif is deploying this in her lab at this point. I don't know if Dr. Latif is.
Irfan bhai, we don't have this right now, but we always send it to Mayo Clinic. We have contract with them. So it's not a problem. Whenever we have to send it, it takes 2 days.
Very good. Very good. So I mean, and that's probably appropriate, because Mayo and Arcana labs like that have developed a lot of expertise in it. This is a very finicky process to do, and training of laboratory staff and techs is important. So it's important for people who are doing it a lot to continue to do it, rather than every lab trying their hand at it and then creating all sorts of confusion.
Thank you.
I hope that answers the question.
Just trying to wrap my head around it. Just like if C3GN is diagnosed, and we as in our hospital have a policy that C4D should be stained in order to, if there's confusion. So my understanding is, if there is a C3GN diagnosed on an initial assessment and the patient is of older age, or there is a monoclonal protein, in that case, you should be sending that patient for pronase digestion. Is that so?
I would say that anyone where you suspect a non-genetic form of C3GN, so if this is a 15-year-old kid, I'm not going to be suspecting anything else. I'm going to say, oh yeah, this is C3GN. If there's some concern, if this is a 50-year-old person, then before I slap somebody with that diagnosis, I insist on pronase digestion to make sure that I'm not missing these deposits.
So it's the age bar. Okay. So one more thing, like if this is a C3 nephritis, and let's suppose I'm in Pakistan, so EM isn't available. So now I am confused regarding that C4D staining is a confusing thing. The research I have produced, or the research by Dr. Sethi, it's not conclusive. It's just appetizer, just giving a thought process. Yep. So we aren't really sure how to use that C4D in full interpretation of a clinical scenario. So is that right for me to think that if the patient is having a C3 low, and after a certain time, the patient is still having a low C3 with active urinary sediment, I should continue to believe that this is a C3GN without any genetic testing and something like that? For example,
as you ask insightful questions. So you're right. So this is a very, very difficult area, like I was talking about. So, if you want to do a thought experiment, think of a 20-year-old with, osteomyelitis or something with Mpgn, right? Post-infectious GN. You biopsy them and it looks like Mpgn, and Dr. Latif tells you, yeah, I can see subepithelial humps and inflammation and yada yada yada, and this is post-infectious. But 6 months down the line, you're still seeing hematuria and proteinuria, and like what's going on, and you biopsy them, and this time around all you see is C3. So what has happened here? What has happened is what started as an antibody driven process has now metamorphized into a complement driven process, because the infection has unmasked an underlying complement genetic abnormality. To make things more confusing, there are C4 nephritic factors, and there's an animal called C4 glomerulonephritis now. So you can have that flavor there, we would light up with C4, and sometimes that kind of confuses things. But you're right. I mean, there's really, without C4, etc., or C3 for that matter in the blood, C4 in the biopsy can sometimes help you distinguish, but it's more of a confirmation bias because its ROC is around received operative curve is pretty close to midline, and Mayo has been doing a lot of work on this. And the way to tease this forward would be to go back at the granular level. So what they do is they actually study it, just as that cluster paper I showed you. What they would do is they would do a laser microdissection, and then would do mass spectrometry on that specimen to try to figure out what are the different proteins in there, and then try to reconstruct what pathway are we looking at, which is dominant. And eventually we'll be able to tease this out. It'll just take some time.
So I have, I think, few questions, and it's already 2:26. So I thought we can have like quick answers. So first question is about eculizumab. Is there any other drug available which is an alternative to eculizumab? So in Pakistan. So that's one piece. And second piece is like, say we don't have eculizumab, what should we do? Okay.
So the first thing is, I don't believe Ultimoris, which is the longer acting C5 inhibitor, has been marketed in Pakistan. I don't think Avocapone is marketed. I don't think Avocapone is C5a inhibitor. And I don't think any of the other complement blocking proteins which are in the pipeline are available in Pakistan. So I think from a complement blockade standpoint, you're probably restricted to eculizumab. And if you don't have eculizumab, then your only game is to use MMF and steroids, or sometimes cyclophosphamide and steroids.
So I think there was a question about role of plasma exchange in C3 glomerulopathy.
Yeah, that's a very interesting question, right? If you've got nephritic factor there, it should respond, and the results are very spotty. So it looks like whatever is being generated is sapped up in the tissue. And, it is very interesting. These things stay active for weeks and months. So when you've got HUS, right, and you start freezing them, the kidney starts clearing up. If you biopsy after 3 or 4 weeks, your SMAC would be gone. So you're actually very effectively dealing with complement in that particular disease. But with C3GN, 3 months, 6 months later, you still have a lot of SMAC there. So these are slow processes, and whatever is tickled the process continues to drive it. And therefore, pheresis has been up and down. So if you've got a factor H antibody, that would work. Probably, that's probably the only thing in which pheresis works in this domain. But if you've got a nephritic factor, a C3 nephritic factor, or a C5 nephritic factor, it's probably not going to respond well to pheresis.
Thank you. There was a question about DNA JB9 stain. This looks like a fighter pilot to me. Is that available in Pakistan?
I do not know the answer to that.
Okay. I don't know this either.
Our Pakistani friends will have to.
Not available.
Aurangzeb, say that again.
No, sir, it's not available because
you should try to get that, because it's an immunoperoxidase based stain, so it should be fairly simple to do, and you might be able to stumble on a bunch of fibrillary cases which would be impossible to diagnose otherwise, based on histopathology and immunofluorescence. So the 2 cases that I presented, the second case that I presented, Mpgn on light microscopy and IgG and C3 on immunofluorescence, you have no idea what you're dealing with till the time you actually do a DNA JB9 or do an electron microscopy, which would confirm that diagnosis. But obviously, electron microscopy is not available freely in Pakistan, but DNA JB9, any lab should be able to do that immunoperoxidase. And Shanila, do you see a big problem with labs running that, mechanistically? Maybe she's gone for lunch, so, okay.
I think that's a good help. If this is available, then this could be alternative to the EM.
Yeah, the thing is, the Shaukat Khanum people have been really kind regarding most of the things that we have done. Even that C4D staining thing, that was the request, and now they are staining everybody who is having a diagnosis of C3 nephritis, at least for us. But the thing is, logistically, unfortunately, I should make a comment just as an appetizer for the nephrology community, so that we can further build up pressure on the diagnostics of private sector. AA stain isn't available. AL stain, kappa lambda staining isn't available. I have a patient right now who is having a juvenile idiopathic arthritis with amyloidosis, but AA stain wasn't done. And these are the so basic things. Then when I tell them these things should be available, I have asked them for LEC2 staining, because Punjabis of British Columbia, they have a certain positive predictive value in it. But the thing is, the business point and the number of patients that we can produce, all these things when get together, only then a private sector hospital is compelled towards bringing a stain towards it. But yes, I would request them again to bring that. They have helped me a lot, but at the level of pathology, they are helping. But at the level of institution, probably all the nephrology community of Pakistan and probably the PSN needs to write down a letter that we need LEC2 staining, we need AA staining at least, kappa lambda staining at least. Because usually I am ringing them up और वो मुझे कहते हैं शेयर करते हैं, मुझे email भेजो, मैं भेज देता हूँ. कुछ दिनों बाद कहते हैं वो validate नहीं हुई. He is working on it, but मेरा ख्याल है pressure build up की ज़रूरत है. I think मैं इस meeting की capacity से बाहर निकल गया, but इस meeting का मेरा ख्याल है फायदा होना चाहिए कि तमाम लोग अपने अपने सेक्टर से कोशिश करें मनाने की, तो इसी तरह ये स्टेन्स वगैरह आना शुरू हो जाएंगे.
I think a point very well taken. Maybe one or two more questions. So one question from one of the participants, Sabita, is that diffuse MCGN versus focal segmental MCGN, is there any difference, and should the treatment be same or different?
Well, I mean, it just probably signifies the stage as well as severity of the disease. So, if it's a mild disease, sometimes you can get away with lower levels of immunosuppression and RAS blockade only. If it's more severe disease, then you have to treat with the full force of therapy. So it just signifies the place where that patient is and the relative severity of disease.
Thank you. We have two questions from one from Dr. Ishad Ali. Can you, may I ask if you ask your question yourself? Those are just sent to me as direct message. Are you here?
So, yes, I'm
Please,
here. Sorry.
आप जरा खुद पूछेंगे तो जरा ज़्यादा बेहतर होगा, मुझे ऐसे लग रहा है.
Thank you very much. Basically, I wasn't getting that option of everyone, so I directly texted you. Sorry. So my question to Dr. Agha is, when we stain for IMF it's C3C. So can we miss C3G because there can be any other breakdown product there? This is my first question.
Okay, I'm sorry. When we stain for what?
C3C on IMF when we are looking for C3 deposits.
Sure. And so the question is what?
So is there any other deposit on renal parenchyma?
I see.
So we can miss C3G.
Well, the sensitivity of the stain is pretty good. There are people who have looked at staining for C3D, as in David, and I don't think that has been an issue. Well, Shanina is probably off the call, but I don't see that is a major issue. No.
And my second question is, to label someone as immune complex, the minimum requirement is +2. So is that true?
Yeah, I mean, it again is a very pathology specific issue, but in order to label somebody as immunoglobulin driven MPGN, there's two things that you need to have present. The first is you need to have immunoglobulin staining demonstrated. And the second thing that you have to demonstrate is that the C3 staining is not more than 2 levels above that. So if your IgG is staining at +1 and your C3 is staining at +3, you can then label it as C3 dominant Mpgn. On the other hand, if your IgG is 1 and your C3 is 2, the staining is weak, but you can then say this is probably an immune globulin driven disorder. So, you know, it is very difficult in all cases to put them in clear boxes or clean boxes. There's a lot of mechanistic issues. Sometimes your stains fail. Sometimes the stains are up and down. So you have to sometimes look at the complete picture to make a diagnosis. But from a criteria standpoint, even if you're seeing light immunoglobulins and the C3 is much brighter, you can label it. So if you've got 1+ on IgG and 3+ or 4+ on C3, you will label it as C3 dominant. On the other hand, if you've got 2+ IgG and 3+ C3, then that becomes an IgG driven process.
Thank you.
I think we addressed all the questions in the chat. I hope so. But if I missed anybody or any questions, it's okay to ask directly. Please, it's always better if you ask the question directly.
So,
Two more.
Just one question.
We charge one like quarter for each question now.
All right, I'll pay
Yeah,
that.
5 questions per session are free. After that, we're gonna charge you.
Okay, I'll pay that online. Okay, sir. So one thing is, you have already mentioned that this is a very heterogeneous group of diseases, so we aren't really sure how to answer all of it. But if we are saying that C3GN, post-infectious GN, C3GN, DDD, probably they are just related to each other. They are the beads of the same string going towards each other. But there isn't any facial lipodystrophy.
No, I want to make certain that I clarify. So I'm sorry to interrupt, but let me just make sure that I clarify that point. They are not really beads of the same string. All I'm saying is that sometimes when you've got post-infectious GN, that triggers C3GN, just as an infection without post-infectious GN can trigger C3GN. So they are very different disorders as we understand them today. But one can lead to the other. Doesn't mean that one is similar to the other. And C3GN, C3 glomerulonephritis, and dense deposit disease are similar but distinct disorders.
All right. So we can start with the post-infectious GN, but the complement deficiency can unmask, and then there can be a C3 nephritis precipitated, and we may come to that conclusion later on, about 3 months' time, maybe.
Correct.
So, all right, C3 nephritis and dense deposit disease, the fusion abnormalities in CFH factor and all that, but it's still a separate disease. You know, I was seeing the data from Mayo in which the mass spectrometry data was published. They were saying that I think it was C3 nephritis, which was having more of C5 convertase, and dense deposit disease having more of C3 convertase. Then dense deposit disease may be having a facial lipodystrophy and some extrarenal manifestations. C3 nephritis sticks to the kidney. Now, can we rationalize that to this level, that how is that happening?
Yeah, absolutely, because it just depends on where your genetic mutations are. So, you know, CFHR is one set of genes which we have studied in quite a lot of detail, but each one of these mutations in C3, in C3b, in factor B, in factor H, factor I, MCP, all of those are you know, distinct disease genotypes, and they present with different flavors of the disease. So it depends on what your genotypic problem is, which is going to lead to what your phenotype is going to be. So there's a distinct set of genetic abnormalities that drive the patient towards dense deposit disease, and a distinct set of genetic abnormalities that drive you towards C3GN.
And finally, for all of our friends from USA, UK, or maybe from Australia, in Pakistan, how would you suggest we should treat somebody with C3G and not responding to MMF and steroids? We don't have eculizumab, we don't have EM, we don't have genetic analysis.
I think if you've got somebody with fairly aggressive disease, you can try cyclophosphamide, but results for cyclophosphamide and rituximab are not that good. And at that point, you will be limited in how you can respond to that if you don't have access to eculizumab also. And eculizumab may or may not work. So these are difficult diseases to treat. I mean, I was treating this patient in the US. I had access to MMF, I had access to eculizumab, and yet the patient romped to ESRD in 3 years.
Okay, I have a question. Can I go ahead?
Please, can we make this the last question of the day?
Okay, it's all up to you. Okay, so basically, hepatitis C is not uncommon here in US also, but very common in Pakistan. And luckily, I have not treated any patient with hepatitis C related glomerulonephritis for some time. Last time I treated, direct antiviral medications were not available. So I treated with rituximab, and he did pretty good actually. So in Pakistan, are you folks seeing a lot of patients with hepatitis C related Mpgn? I don't see here much as far as my experiences, and how you treat that other than antiviral medications.
Well, it all depends upon what's the presentation. If it's a subnephrotic proteinuria with normal renal function, directly acting antiviral may be good. If it's nephrotic syndrome or if it's a nephritic syndrome, in that case, immunosuppression may be indicated with directly antiviral agents. And if it's a cryoglobulinemia associated with the hepatitis C, then rituximab.
Yeah, that's what my question. So you using rituximab also? I'm talking about membranoproliferative, right?
Whereas I had a patient like this, patient with nephrotic syndrome, cryoglobulinemia, and hepatitis C.
Okay.
So Hep C was treated. He needed rituximab, and every 6 months there is a skin rash appears and proteinuria starts to rise. So this patient, we kept him on rituximab, I think every 6 months for a few years, and then things settled down. So he every time you give him rituximab, responds very well, both for rash, proteinuria, and creatinine starts to settle down.
So there's some B cell dysregulation that happens with hepatitis B, and that's why hepatitis B is associated with several B cell disorders. Lymphomas, etc., are more common in these patients, and so there's 3 levels at which you want to look at this. The first is you've got some Mpgn, you've got some proteinuria, the kidney is not very angry, you don't have cryos, you don't have crescents. Those cases you just treat with direct antiviral therapy now, and everything gets better once the virus goes away. There are people who present with an acute kidney injury, you biopsy them, and they've got cryos and they've got crescents and fairly angry and aggressive course. Those are the patients that need respite immunosuppression. You do some pheresis, you use some steroids, sometimes give rituximab, but at the same time start direct antiviral therapy, and that gets better. But there are some cases like what Umar is describing, where you have aberrant B cell clones that require periodic suppression by rituximab. So sometimes they will need 2, 3, 4, or even cyclical therapy to stay under control, but that is very rare. It is interesting, sometimes cryos are unmasked several months after they have been treated with direct antiviral therapy, and those actually also, if the virus load is still gone, which it usually is, they respond very well to rituximab also.
Yeah, this is what happened to my case too. So
I was talking about the patient who had cryoglobulinemia, so that was treated with rituximab just one time, and then he went to remission for a long time. So do you guys see a lot of cases in Pakistan, because hepatitis C is even more common there?
Yes, we do. Hepatitis C associated glomerulonephritis is very common. Unfortunately, cryoglobulinemia assay isn't available. Even if it's done by a few of laboratories, it's not done in the proper way it should be done. And we are trying to communicate with the different labs. The government sector labs are relatively not well equipped. The private labs, usually they try to do it, and after a while they stop doing it because they say that the business isn't that much and the people are not really sending tests, and this is the reality.
Is any decrease in cases since we have this direct antiviral medications available, or is any change since then? The number of cases, or not that many?
Well, I can just tell you about my department and my own practice. I feel like, I haven't gone through the stats, but I feel like there is a decrease towards lesser cases of hepatitis C associated cryoglobulinemias and glomerulonephritis, but still there are many. And they are not properly diagnosed. Cryoglobulinemia is hardly if ever diagnosed. It's a clinical diagnosis. You know, the fastly positive rheumatoid factor helps us in diagnosing cryoglobulinemia sometimes. So this is the level of
a lot from my colleagues in Pakistan, because they have, in some cases, they have more experience. So how about hepatitis B? You still see a lot of hepatitis B related renal issues that we fortunately don't see much because of the vaccination we have here. So any membranous related to hepatitis B over there? You see any cases or not much?
we still do, and I think I still have a patient admitted with hepatitis B associated glomerulonephritis, and but they are relatively less. After I think in 2015, I used to remember there was a lot of patients, but as you have asked this question, and I am trying to forget that, they're decreasing in number. You're right.
Okay.
So we have now 13 people left in the Zoom room, including Jackie as well. So maybe I would request that we wrap it up. So thank you, everyone. We have the recording, I think, available one way or other. It will be shared via YouTube, and we can share it back to the group. Jackie, you want to say any final words if you're still there?
I am still here.
Excellent. Thank you.
Just please watch your email for the evaluation. I'll be reaching out to a few people who weren't registered who provided their email so that we can get you credit. And yes, as soon as I get the recording, I'll share it with you and you can get it out. And I guess next session is Sunday, May 2nd.
Yes, that's true. And I think it's TMA, right? Dr. Abbas, you are doing TMA, I think, next time?
Yes, I'll be doing it. Yes.
Okay, excellent. That will be fun session too.
A lot of fun.
All righty.
Okay.
Happy Ramadan.
Okay. Thank you.